Hi, everyone, and welcome to another Global P.A.D. Impact Award presentation. Today, it's my great privilege to honor an extraordinary individual whose work has fundamentally shaped vascular diagnostics over the past half century. Hard to believe, right? The Global P.A.D. Association's Lifetime Achievement Award in Vascular Diagnostics recognizes professionals who have made substantial career spanning contributions to vascular imaging, techniques, education, quality standards, and patient care, of course. No one embodies these qualities more thoroughly than Denise Levy, whose remarkable journey began in 1973, I believe it was, as an X-ray student at Beth Israel Hospital in Boston, Massachusetts. And throughout her 50-year career, Denise has consistently elevated the field of vascular ultrasound, most recently serving as Vascular Lab Technical Director at Hill Vascular in Campbell, California, right near me. And in fact, she had my dad as a patient. Her contributions extend far beyond her clinical work, though. As co author of important textbooks, including the Atlas of Grayscale Ultrasonography, she has helped educate generations of technologists. Her expertise in vascular lab accreditation has established quality standards that protect patients nationwide as well. What colleagues consistently note about Denise, though, is her unwavering commitment to diagnostic precision and patient care. Her professional philosophy: be curious during an exam, look for subtle changes, detect disease early. It can change everything for a patient, has guided her approach throughout her entire career, resulting in countless early diagnoses that have saved countless limbs as well as lives. So I am honored to present the Lifetime Achievement Award in Vascular Diagnostics to Denise Levy. And I am so excited to have her here, but I'm also excited to have a guest co-host, Dr. Brad Hill, who has worked with her for a very long time and I think helped lobby to get her to get back in vascular diagnostics because she had crossed to the dark side into industry. Okay, it's not really the dark side. I'm just kidding. But anyway, big congratulations to Denise. We are so excited and so honored to have you here.
Well, I'm honored to be here, and it's been quite a year looking back, 50 years. And it's like Brian Sapp told me, I was born the year you got registered.
So, who's
So
Brian Sapp?
Brian Sapp is president of SVU, and he's done an incredible amount of work in PAD and
Yeah.
Truffle's veins. He's very good at venous disease. So Brian's been a big advocate and leader in the field, and he also gave me that award that's up on my mantle
Behind you.
there of
Yeah.
my 50 years. It was really quite a surprise when I was speaking at his conference in Tulum, Mexico.
So, was it weird just suddenly waking up and you're like, oh my gosh, it's been 50 years. Are you kidding me?
I
I've
know,
been
I
doing this
know,
how long? Wait, what?
I know. Well, it's been a great journey, and like I said, I started in X-ray, and from there, you had to be an X-ray student to get into ultrasound school. So I went to
Okay.
Oklahoma from Boston and worked with Ellie Schnitzer, who was one of the founders of the ultrasound technology with Joan Baker. So it was Ellie was instrumental in getting me into ultrasound school. I was there for a full year round trip, and then went to Connecticut and worked at Yale. And we did a lot of publishing at Yale. I mean, I was publishing papers with 2 years experience. I mean,
Oh
we
my
did
goodness.
12 papers in 3 years and a
You're
book.
kidding.
No, I'm not. And if I wanted to go to a conference like AIUM, I had to present at least 3 papers. So that is quite a learning experience. And for
So,
me to graduate ultrasound school, I had to present a paper, and my paper was on detection of needle biopsy with thoracentesis. And I
what
ran
is
around the
that?
hospital and with my A
What
mode,
is that?
showing them where to put the needle to tap the chest. Yeah.
And
So that
what
was my
is
first paper.
thoracentesis? What is thoracentesis?
Thoracentesis, where they put a needle
Thoracentesis.
into the lung cavity to pull out fluid. So I
Oh,
would
wow.
show them just on A mode, handheld A mode, where the fluid was, the pocket, and they would put the needle in.
Oh my
It was
goodness.
quite interesting. Yeah.
So what drove you to first X-ray school, and then what was that catalyst that led you to say, "Hmm, I want to go into ultrasound"?
Well, I think it was Ellie. Ellie was at Beth Israel, and he
And
told
Ellie,
me,
it
he
was
said, Ellie
okay.
Schnitzer, he passed away 2 years ago, but he was one of the founders of ASUTS, which was now ARDMS. He and Joe Baker were founders of ultrasound technologists, all the way to Congress and the Senate to get us accredited for nationwide, so that we could, establish credentials and guidelines, and make sure that people knew what they were doing once they got registered.
So
So
you literally were, I mean, you were there
yeah,
from the very, very
I was one of the
beginning.
first 300 people in the nation to take the exam. So my number is 212.
Wow. That's
Yeah,
incredible. And then,
yeah.
Dr. Hill, you must feel very lucky to have one of the pioneers in the entire industry that has worked with you for now how long?
Oh, absolutely. 4 years. I'm fortunate to have had Denise join me for her last 4 years scanning,
Yeah.
and with all her cumulative knowledge over all those years, and actually helping the societies with their guidelines, and getting my lab accredited, and then reaccredited when it was time to do that. I mean, she was there and kind of led that process. So we were very fortunate to have Denise, and we had fun sharing stories about individuals we'd worked with in the past. Maybe Denise, why don't you talk about your training that took you to Oklahoma, of all places?
It was the only accredited school in the country at the time,
Oh
and
my
they only
goodness.
accepted 4 students. So I had to, yeah,
Wow.
it was quite an experience.
Yeah, and you were
And
there. How many years were you in Oklahoma? Was it just one
I was
year?
only there a year. It was a
Yeah.
year program, but you had to be an X-ray tech as
Yes.
well.
So
So,
I mean, this.
and then
I mean,
I worked in a trauma center at night, put myself through school.
but
I
it,
saw a
it
lot of
speaks
broken
to
limbs come through the
your
door.
drive and your passion for the field and ultrasonography. You went there, you did that fellowship, and I had a similar experience in coming to California because I wanted to work with sort of the foremost expert in the field of medical device innovation back in the mid 90s. I came to California to work with Dr. Tom Fogarty, cardiovascular surgeon extraordinaire, inventor, entrepreneur, who was faculty at Stanford at the time, and had devised the first system for aortic endografting that was in the process of FDA approval. Stanford was the clinical site. The primary investigator or principal investigator was Chris Zarens, who worked with Dr. Fogarty. But anyway, I interviewed with Dr. Fogarty. I was really impressed with his what he had done and what he was building at Stanford and Silicon Valley Medical Device. So I came to California to work with him. And you similarly wound up in Silicon Valley to work with the best and brightest in the evolving vascular surgery field. And you too worked with Dr. Fogarty. Is that right?
Yes, and what's interesting is this is the paper that I published in 1990, and it is what Jill talks about now, the Tarvis parvis.
Jill Somerset, she was
So
our pioneer of diagnostics
yeah,
last year
so
for
what we did
2024.
was we looked at renal arteries, and that we determined that anything greater than 80% had a Tarvis parvis in the distal renal artery. So even though you couldn't see the renal artery origin, you could tell there was an 80% lesion just from looking at the distal renal artery. So what I did was I was able to do 50 arteries before and after atherectomy with Dr. Fogarty and John Simpson. So what we did was I scanned them in the morning, They went and had their atherectomy, got their renal
And the
artery fixed.
atherectomy is the roto-rooting, so people
The
know it as the
roto-rooter,
roto-rooting.
they were
Yep.
cutting, they could only
Cleaned
do,
out the
they had,
arteries.
yeah, they had to do renal arteries before they could go to coronaries for this. So what I did was I had permission to actually study the patient in post-op and look at the distal renal artery, and the tarvis parvis was gone. So that we determined that, yes, the tarvis parvis does work, and that an 80% lesion will have a delay in rise time in the distal renal artery. And then it
So
was
for
gone
us,
when they were in post-op.
what is a tarvis parvis?
It's when you get a delay in the rise time, like Jill, you measure it so that it looks like that. That's what the waveform
Okay.
looks like.
Gentle slope instead of a sharp up.
Instead of going straight up,
Yeah.
it's very delayed and like a pyramid, and not straight up like systole. So that's what we determined. And the one mistake I made was Dr. Hayden said to me, Denise, you've got to put Fogarty's name on this. And I did all the calculations and everything. And I said,
Yeah.
well, I don't know if Dr. Fogarty wants it on there, but that was my biggest mistake, was not putting his name on my paper. And that was
Oh,
in 1990.
because sometimes, I mean, especially with his name, it would just drive it, forward, right? And would have
And
gotten
I
it.
got to spend time with him 2 years ago. I
Yeah.
went to his foundation and sat
Oh,
and
great.
talked with him. It was just, it was on my bucket list. It was something I wanted to do. And it was just so rewarding to go and see him.
What do you think? So do you feel like that was your most impactful paper publication that you ever wrote, or do you have
I
another
think
that
so.
you're most
Yeah,
proud of?
because, I had to do it on my own. And the good thing was, post-op, normally you can't touch a patient. The nurses won't let you. And I said, well, Dr. Fogarty said I could. I said, okay, no problem. So
What
it
Dr.
worked out
Fogarty
great.
says
It
goes.
really was an eye opener, especially for me, seeing the patient that morning and then seeing post-op a couple hours later. It was just really impactful. And we used to look at that quite a bit in an SFA and see the lesion and see there's 80 to 90% or occluded, and then you could see the change in the waveform immediately after.
So
So
what point did you get passionate about legs? Legs of all things. So peripheral artery disease, the poor circulation, and mainly the leg arteries, then also chronic venous insufficiency, possibly even DVTs along with that, with the veins.
Yes. Well, when, Dr. Hill works up the patient, there's always a duplex ordered. There's always an ABI and a TBI ordered. Plus we do the pulse volume waveforms as well.
Right.
It's so important on these diabetic patients. But when we bring a patient in, the first thing I do is the distal iliac artery. What does the waveform look like? Is it delayed? Does it have a good upstroke? Is there a stenosis? You look at everything. You look at the size of the vessel, you look for any plaque. And then if I know that Dr. Hill is maybe going to fix somebody, I'll look at the common femoral and the external iliac to make sure he can put a guide wire in there. Because if there's a lot of plaque on the anterior wall of the common femoral, I know he can't put a needle through it. He's going to have to go, another way, maybe SFA. But whenever I do a case, all I'm thinking about is how are we going to fix this patient? And is there a lesion and does it need fixing? So you look for any change in your Doppler as you go down. You look for any short segment stenosis. You look for 3 vessels run off. You look to see if they have a wound. Is the wound at the heel, perineal? Is it at the foot where it's a TP? There's so many things that you're going through when you're doing the patient. Plus you're talking to them because you want to relax them. And I always tell my patients, thank you for coming on time, because that really makes our day a lot easier too. So that we can see patients on time, get them through on time, and try to alleviate any anxiety they have.
So why the legs though? I mean, you could literally have picked any area for ultrasound and you have generalists out there, was there a reason? Was there a catalyst for you deciding that you wanted to focus and specialize on the legs?
Well, we do everything. We do carotids, aortas,
Oh, you do those two? Oh, wow.
and
Okay, you do a lot
we
there.
do a lot of venous compression. We do a lot of venous disease. We do a lot of reflux studies. So there's, patients that come in the morning, then there's patients that come in the afternoon.
Ah.
So it really works great with Dr. Hill because the whole office knows what's going to happen with a patient.
Yeah, and I think it's really wonderful hearing Denise, kind of talk about her thought process and how she approaches patients. And you can tell by listening to her, she sounds like a physician. She's thinking about the patient, as a whole, and not just that study, but what happened before the patient got in the exam room, and then what's going to happen after the patient leaves, and how am I going to approach the problem, not just in making the diagnosis, but actually doing the treatment as well. So that's a learned process. So students, Denise has been teaching students for many, many years, and we've been part of the Gurnick Ultrasound Academy, their registered vascular technology program for educating RVTs. We've had students with Denise most of the time that she's been with me. She's been, to really understand the full breadth of the practice of vascular surgery and how we manage the patients, not just do the study. So it's really wonderful to hear her talk and how she approaches these studies that she does. So one thing that also I think is important for the listeners to understand is that for vascular surgery, it really is, sort of an evidence-based practice that data, so real measurements, sort of a scientific approach to diagnosing the disease. We have measurements of the blood flow velocities, and that correlates with the narrowing degree in the artery, how much obstruction is there in the artery. It's very, very precise. And so the measurements have to be done meticulously. We use criteria to make interpretations and make sense of the information that Denise makes, the measurements she makes, she puts them on a report. I look at the report and do an interpretation that then helps me decide what is the best treatment for the patient. So it's very sophisticated technology that we use. It's evidence-based, and it's really the best way to practice. It's not like the old school where you go and you check the pulses with your fingertips. You think you know what you're seeing there just based on a physical exam. It's very, very different. And I can't imagine not having an accredited vascular laboratory, as part of my practice. And Denise really made that possible for me, and I'm so grateful for that.
And that's what's also incredible.
We're accredited in all 4 modalities. We're accredited in abdominal, carotid, arterial, and venous.
Oh,
and you
that's
have to have
amazing.
so many cases submitted, and they all have to be positive.
So how did you two end up together over there at Hill Vascular?
Well, I'll tell you my story, and then let's hear Denise's story.
Okay.
So, like I said, so Denise has been in the South San Francisco Bay Area. I don't know how many decades, Denise. You can talk about that, but I arrived here in '97 as surgery at Stanford University. I came to work with Dr. Fogarty and also Dr. Chris Zarens and the other faculty there at Stanford. I finished the fellowship and I stayed on faculty for 5 years. So I was based at the university, but I was also working at Kaiser Permanente in Santa Clara. And then in 2004, I moved to Santa Clara Kaiser, where I practiced years or so. And then I did an early retirement, started my own practice here. So we were both in the South Bay. Really didn't have any direct interaction until I started my practice. And I met Denise when she was working for Philips as a medical device rep. And she was demonstrating the Phoenix atherectomy device, and she made an appointment to meet with me. And I didn't know what to make of Denise at first, because she was like, okay, let's get this thing going. I want to show you this device. And I was going to see it no matter what. And she showed it to me. She did a beautiful demonstration. And I was really impressed with the device when she demonstrated it to me. And I subsequently started using it. I still use it today as a result. But that was my first introduction to Denise. She told me that she was RVT and did ultrasonography for so many years. And then she went on to do this medical device work. And not only did she do the work, but she was the best rep for the entire Philips organization nationally for vascular medical devices. And she was blogging and she was doing a lot of social media, constantly producing informative pieces for social media. And then it was during that time with Philips, I think a couple of years, she and I had more interaction. We got to know each other, and we were so fortunate that she decided to come and work with us at that point.
Yeah, Denise,
Yeah,
what's your side of this story?
Well,
I'm
I
curious though
was,
why you ended up, if you were so
I was,
passionate and you were doing so great,
I was
sorry,
a
so
rep
you
for
were doing
Philips.
so great. But you
Yeah,
were before that, why did you end up at Philips? Why did you end up going, you were a pioneer?
I was working with one of the reps, they would come in and they would, we would do stents and balloons and whatnot. And
Yeah.
my friend Manish and Art, they worked for Philips and one worked for Abbott. And he said, we got an opening and I think you would do great. Because, I used to do a lot of balloon angioplasty under ultrasound guidance. And so, it just worked out that I just kind of needed a change. I'd been in a private office. I worked with Dr. David Chang, who was the co-inventor of Silk Road. I did the first Silk Road patient. And I also worked with Dr. Schubart, who worked with Dr. Hill. And they came to me and said, well, we have this opening, we'd like to interview you. So I took the job and it was a real eye-opener being a vendor, because a lot of people don't realize it, but when you are a vendor to go into a hospital, you have to have the same testing and credentials as an employee of a hospital. You have to have bloodborne pathogens, radiation safety, all of the parameters that you need to hire an employee. You have to take those exams. Plus, you have to pass all your onboarding for Philips. I had 11 products I was responsible for, and you had to know all of them. I went to boot camp testing me for 2 weeks solid, and you had to pass final exam, had to be greater than 80%, or you weren't hired. So I had a great team. I had a wonderful time. And I was at my old hospital. I used to work at Good Sam for 20 years, and I supervised a number of years there. And I was in the cath lab doing a case with Dr. Hill and Dr. Quayam. And I knew Dr. Quayam through cardiology at Good Sam. And he said to me, Denise, you used to do ultrasound, didn't you? And I said, yeah. And he said, you need to go work for Dr. Hill. So selfishly, he wanted me to work for Dr. Hill so he could send me patients. And every time we got an order, it said, Denise only from Dr. Quayam. He still does it today. But yeah, I mean, the Philips taught me a great deal, and obviously more interaction with doing cases, balloon angioplasty, atherectomy, laser, and all the different devices. And I covered Napa to Salinas, and I got to work with Dr. James Zimmerman. I did workshops with him, and I worked with him with the Fogarty group. He was with the Fogarty group. So it was really great to go back and see doctors that I hadn't seen in 20 years and work with them and cover. And I had a great time. It was a wonderful job. I learned a lot, and especially with venous compression, because in ultrasound, we really didn't know a whole lot about it. But then when they did the IVUS with the iliac compression, and I got to work with really
Was that May
great
Thurners?
people.
May Thurners.
Yeah.
May
Yeah.
Thurners.
And then, for Philips, I got to meet Frank Arco, the GOAT
Yeah,
for
he's still in North
thoracic
Carolina, I think, right?
aorta. and we got to see Dr. Lassar would do live cases, and Dr. Adams did live cases.
Dr.
And I
George
met-
Adams. Yeah, he's
and
in
and I
North Carolina,
worked
another
with,
Raleigh. Lazar is in
Dr.
Tennessee.
Leone, Dr.
Oh, I don't know
Leone
Dr.
in
Leon.
Arizona. I went to
Okay.
his lab, and we were there 3 days in training, because Philips will train you out of your territory. You don't train in your territory. So I went to St. Louis and Arizona
You got
and
to do some
Michigan.
good traveling.
Yeah, yeah, it was wonderful.
So how did he
It's
get
really
how
an
did Dr.
eye
Hill,
opener when you become
how
a
did Dr. Hill
vendor
get
and
you
what
to
you're
settle down
responsible
again?
for.
How did
Yeah,
Dr. Hill get you to
Denise,
settle
yeah.
down again? I mean, it sounds exciting. What did he
Yeah.
say? What were the magic words?
Well, it was 10 minutes from home, you know. My husband wanted me to slow down a little bit,
Yeah.
and but yeah, I had a great time. I've always had a good time at a job, and when I don't have a good time, it's time to leave.
Yeah.
And I think that there's options for everyone, you know, to expand your career and go into different things. And I really encourage people that are RVTs to get their abdominal or get their OBGYN. There's a lot of venous disease that you can do with a transvaginal, and looking at collaterals and whatnot for venous compression.
Interesting.
But really, you know, Dr. Hill and I do over 370 ABI, TBIs a year.
Wow.
And, you know, is there a lesion? Do we need to fix it? What was the prior exam? I always want to make sure, and I always tell my students, make sure you know what the patient had before angio. Have they gotten any better? Is there a stent? Is there any blockage? Is there 3 vessel runoff? And if there is a lesion, is it a short lesion? And is it a long lesion? Can we get to it? I'm always measuring the pedals, because I want to know, can he put a 5 French in there, or does he have a bareback? So it's just things like that that I learned with Philips that taught me as an ultrasound technician how big the vessel has to be for a 5 French. So those things you learn, and you have a great appreciation, I think, for duplex.
I mean, not every ultrasound tech has this experience. I mean, you know, you have people like Denise, you have people like Jill Somerset, who's also a pioneer. There are a couple ultrasound techs over at Hope Vascular with Miguel Montero Baker over in Houston that are earning our ultrasound techs of the year coming up very soon. Oops, spoiled the announcement there, but they're coming up. But very few that literally, you know, go above and beyond what they learn in school and truly start innovating and are engaging. I mean, I just can't imagine, Dr. Hill, that you have these conversations that you have with Denise with every other patient. I mean, with every other ultrasound
No,
tech that comes in the door.
yeah, it's been amazing having Denise in our clinic and as part of our team for 4 years. You know, and she actually was so good at looking around. You know, patients so often have multiple vascular diseases. You know, a lot of our patients are dialysis patients. We manage their hemodialysis access. You know, creating AV fistulas and grafts in the operating room, and then maintaining them with fistulograms. And so part of that is doing ultrasounds of the fistulas and the grafts routinely for these patients, but especially if they're having trouble with dialysis, if they're having bleeding around, you know, the time of dialysis, or aneurysmal change, the vein is starting to enlarge. So they very frequently also have P.A.D. Because it's a systemic disease. Their kidneys failed because of high blood pressure, diabetes, and you know that affects the peripheral arteries too. So a lot of them have P.A.D. So being aware of their other disease processes. I mean, Denise is always good at sort of looking at the whole patient to see what's happening. You know, sometimes patients come in for one study, maybe to look at the arm, but they're kind of limping in, and they have some, you know, bandage on their leg or their foot. You know, so it's good to say, hey, what's going on with your leg there? You know, maybe they've got a non-healing ulcer from their P.A.D. But Denise was always great at looking at other structures, not just what the study
Yeah.
was for. So for example, if the study was to rule out a DVT or assess the venous system for venous reflux, and the patient's having some pain, Denise would look at the arteries adjacent to the vessels, to the veins that she was imaging to see if there's any disease there too, and if she would identify it, if there was something wrong, and then bring it to my attention. And I always felt a great sense of confidence when Denise
Yeah.
was scanning my patients, because I knew that they were in the best of hands, always. So Denise is,
Funny is,
going on to the next phase of her life, but I miss her dearly.
well, you know what
Retirement
funny?
is great.
Um, no, I mean, when I have a patient and say they have a focal lesion and an SFA or something, and their ABI is okay, but not great. So I'll run into Dr. Hill and say, do you want me to exercise them? You want me to see if they drop? Because by their symptoms, they had claudication, but
Yeah.
the ABI didn't show it, to be moderate or severe. So I'd say, do you want me to exercise them? And then we would see that they would drop.
Yeah, I
And
mean,
then
that's a
it's,
really
okay,
good point.
now we need to fix them.
Yeah, I think a lot of the listeners may not understand that, and maybe a lot of physicians don't understand it either, is that people can have P.A.D. and have normal pulses. You can feel their pulses, and if they're not exercising their muscles, the demand for the blood flow is not very great. So even with a tight blockage, sometimes the pulses feel completely normal. But if you have them go and walk for a half block or a block or more, the pulses disappear because the vascular bed is vasodilated and they've become symptomatic. So that's a nuance about vascular, that Denise has learned very well, and a lot of the listeners may not be aware of that even if pulses seem fairly normal, it doesn't completely rule out the possibility to have some P.A.D. there.
So it's not enough a lot of times just to take off the socks and feel my foot pulses.
Right.
You've got to measure it as they get up and go.
I think,
I
yes,
tell patients it's like taking a temperature. You want to know if there's something off, comparing your arm to your leg. And then we
Yeah.
also do the pulse volume so that we can see the waveforms, if they're normal, in the thigh all the way down to the toe. And we
Right.
can see where the level of disease begins. So that's also an added diagnostic tool that we have.
It's definitely important, especially for diabetics and chronic kidney disease patients that have more of the bottom up disease, I would imagine.
Yeah.
Yeah.
And my
So
students love doing ABI, TBIs. They love doing them.
it's funny that we still have a lot of offices that don't do TBI. And they stop at the ankle and that's about it. And they do the ABI, they say you're fine, and then they still can't walk. And they call our leg saver hotline and they say, I don't understand. I guess I don't have P.A.D. And we send them to another doctor. They do the TBI, and lo and behold, there's something there.
That's
So
Yeah,
right.
I think the quality of the test is really important. And, if you have an accredited vascular lab, at least there's some assurance that certain minimal standards are being met, because ABIs can be falsely elevated. They can be falsely
Yep.
elevated into the normal range. And if you just look at the numbers, you can be fooled. So the waveforms are really important. If you see blunting of the waveforms, the arterial pulse waveforms, that's an indication there's probably some problem there, even though the actual number might look normal because it's falsely elevated. Toe pressures usually are more accurate. They're not elevated artificially very often, and frequently, you'll get a reliable measurement. So we get a toe pressure that's actually measurable because the vessel is compressible. The disease doesn't usually go into the toe vasculature as much. So toe pressures are really good to have as part of the routine study. We do them routinely for every patient that has an ABI in our lab.
what's the takeaway there for patients who are getting set up for their ABI and or their duplex ultrasound? What should they expect?
Well, I think that, it's a test that's not invasive. First of all, they should understand they're just going to have blood pressure cuffs put on their legs. They're going to have an ultrasound probe sort of pressed against the skin to image the blood vessels. It's not painful most of the time. Blood pressure cuff can be painful occasionally. It provides additional information for the physician to put into the equation to help make a diagnosis, but also to help recommend a treatment plan. So it's really
Yep.
an extension of the exam. It's going to provide that information for the physician. And also the patient should also be aware, it's a test, it's a result. Sometimes results may not be accurate for one reason or another. We talked about the falsely elevated pressures that can be caused by calcium sometimes in the vessels. So the patient,
Non-compressible.
so the patient should be aware of that. So if they, things aren't getting better, if they have a toe wound, it's not healing, they shouldn't just assume, well, the test was reported as normal, so we can just check that box. Because that's not always the case. I think getting expert advice from an accredited vascular surgeon, go to a registered vascular technologist who is accredited doing the test, an accredited vascular laboratory is ideal to get an accurate diagnosis and recommendation for treatment.
How do you know that it's a credit? What is the accreditation for a vascular, for the legs in particular?
We have the world expert right here with us.
Intersociety of accredited vascular labs, and they accredit nuclear medicine and cardiac and MRI, but our main goal is vascular, and that you have to submit cases from each staff. You have to submit one of their cases, and you have to submit, it has to be positive. You can't just give them a normal study showing, everything. And a lot of people say to me, well, what do I have to do for IAC? Well, it's very simple. You have to show grayscale of that vessel. You have to show color flow of that vessel, and you have to do the Doppler. And if you get a stenosis, you've got to do it before, at it, and distally. So it's really simple what to submit, but what they want to know is, can you make a diagnosis? Do you follow your protocol, and do you follow your diagnostic criteria? So there's diagnostic criteria for 50%, 70%, and obviously an occlusion. So that's what you go through for IAC accreditation. And it's a lot of money. There's a lot of money, and a lot of places will only do one modality and they do 4. But what we did was we have an accreditation for every test we do. So a lot of labs will just have, say, venous, and they do everything. But myself and Dr. Hill felt that, well, these tests that we do a number of them, we should be accredited in this. And so we're willing to pay the extra money for each exam to be accredited.
Well, I could definitely tell the difference when it came to my dad. We drive nearly 2 hours to come and make sure that we're doing it at your lab. So I just know from personal experience the extent to which, I know how you do things differently and more comprehensively than I've ever seen anywhere else. And so I think the accreditation, it's something that people should take into consideration. What do they have the accreditation for, and make sure that it's for those specific tests for P.A.D. and CVI in particular, if that's what they're going in for, because it sounds like some of them don't.
And sometimes you'll get a report and it will say suboptimal, could not see the perineal, could not see this, could not see that. Well, you have the tools, you have the lower megahertz, just pick up the probe and put it on the calf. Reposition the patient, hang their leg down or bring their leg up. So you're going through less muscle. You do have the tools to see it. So it's important to take the extra time, like 30 seconds, and find that vessel. So it's important for them to know, is it occluded or is it patent? You've got to know that before you go in and do a runoff, right? So basically you're mapping everything before the angio. So that's easier for Dr. Hill or anyone that's going into a leg, how to attack the leg.
And it's so much better because, practices that don't have access to this type of vascular imaging rely on other types of imaging like CT angiograms that involve much more radiation exposure, much more expensive to do, and unnecessary. So it's better if we see more labs being accredited, more vascular ultrasound being done. It's better for patients. We
Yeah.
make more diagnoses. There's less radiation involved. It's just better all the way around in that regard. And
Well, I
these
mean, I've seen it on people's, they send me their scans and such to forward on to doctors and such. And I see that there are gaps and things that they couldn't see or read or whatever. And I'm thinking, gosh, that's awfully vague compared to the reports that I've gotten
Exactly.
from you, Denise.
right. And having
Yeah,
good
it's
data also, it makes a huge difference, because sometimes, doing intervention is not the right thing to do. And if you have enough data, you can confidently say that. That's great. A lot of times there's not enough data, so people go to angiography unnecessarily. Sometimes it can be bad for patients. That doesn't happen very often, but having very solid, reliable, non-invasive vascular imaging data is
Yep.
incredibly valuable when it comes to making the diagnosis, coming up with a tailored treatment plan for patients, so that you as a physician can be assured, and the patient also be assured that their treatment is the best possible treatment for them. So having the vascular lab, I can't imagine not having a vascular lab. I've practiced now for, over 30 years, and I've always had access to a vascular lab since I was a general surgery resident. Never have I had a time where I didn't have that available to me. I know a lot of vascular surgeons don't have it, or maybe they rely on a hospital radiology department, which is a different level of imaging and sort of data reliability, I should say. Their hospitals are great. I don't want to put the idea out there that if you have images done or ultrasounds done in hospitals are not reliable, because that's not the case at all. But it varies a lot, and most of them are not accredited
Yes.
through the IAC, like you'll see in most vascular laboratories. So it's just something to be aware of. MRI is great. MRI doesn't require a lot of radiation, but it is much more expensive. And as we talked about, CT involves a lot more radiation than you'll have with ultrasound. So, it's good to see vascular labs be successful, to see them, crop up in the community,
Yeah.
in different places, because they're so valuable in this type of practice.
And so we have a limited amount of time left here. So I want to get to some fun questions that we ask every one of our award winners. But before I get to the case you learned a lesson from, I'm curious, Dr. Hill, if there is a lesson you learned from working with Denise, was there a specific case in working with Denise that just stands out to you and you just say to yourself, oh my God, thank God she was here?
Yeah, well, there was a patient that came in with leg pain and swelling, and the patient was having an ultrasound. The thought was that she had actually a venous problem. She had an ulcer around the ankle. It was kind of a typical venous stasis ulcer type problem, very painful. And Denise was doing an iliac vein ultrasound on this patient. And she, like I said earlier, Denise was not sort of bound to the study type that was ordered. I mean, she looked at the artery too, not just the vein. Sure enough, she found like a 80% stenosis of the common iliac artery in this patient. And that's what was causing her ulceration. So eventually would have gotten to the diagnosis, but it probably would have required another study. It would have delayed the care for the patient. So we had the patient in the hospital. This is something we had to do at the time because I didn't have my OBL, my angio suite at my office was not operational at that time. So I had the patient go to the ER immediately. We had her in the OR. I think it was that evening, actually, about 6 p.m. We're able to treat and stent her very tight common iliac artery stenosis. But that's just one example of many similar cases where Denise, made the diagnosis, looking at structures that were not actually part of the ordered study.
Yeah, because she treats the patient, right? She's not just treating the vessel that's on the paper,
Right.
that's on the order. She's like, I am paying attention to the patient. I'm talking to the patient. And I'm
And-
getting more information that's leading me to where we want to be, guiding me where we want to be.
And this patient
So
actually embolized from this lesion too. So it wasn't just an obstruction that was limiting circulation. The patient
yeah.
actually embolized from there. And had she not made that diagnosis, and we anticoagulated the patient, so a lot of things happen as a result of that. One example.
One of many. So
One of many.
Denise, describe a case that you learned a lesson from that other physicians, clinicians, technologists can learn from. It could have been a success, it could have been a failure, but what was the lesson that you learned that others could learn?
We had a patient that came in, he was, they said he had no pulses. Young graduate student from Korea had flown in, and I'm scanning, they ordered an arterial left. So I'm scanning his leg, and the arteries, are fine, but there's no plaque. He's a young man. And the velocities are going down, down, and down. So I got to his pop and I looked. Well, he occluded his entire venous system. So it backed up so that he did not have any pulses any longer. So I called the doctor and I said, we need another order. He's got extensive DVT from his groin down to his toes. So he had no outflow. So that's the reason why he had no arterial signal. So
Wow.
it's kind of looking at, what's going on. This doesn't make sense. And it made perfect sense because here he is, a young man. Why would he have P.A.D? He got off a plane. He's dehydrated. He's got DVT. So, years ago when I used to go down the ER to Good Sam, they would say to me, Denise, what should we order? I said, well, is the leg swollen? We'll get a vein. Is it cold? We'll get an artery.
So describe a case where a patient should have been diagnosed with peripheral artery disease sooner, but wasn't, and because of that, presented on deck for complex revascularization or even amputation. And really, this is to raise awareness of the delays in patients seeking care due to a variety of issues, from sciatica to gout to arthritis to diabetic neuropathy. So is there one that you can share with us that patients can go, oh my gosh, my doctor told me that I needed a spinal fusion, but I may have PAD.
There's been a number of patients that come in and we can't tell if it's claudication or neurogenic claudication from their back. So we get a number of those. And first, what you can do quickly is an ABI, TBI. And if that's normal with triphasic waveforms, it's most likely their back. You can also, test them for claudication by exercising them. But yeah, I mean, we've had patients that have come in and said, I'm a smoker and I can't walk as well, and it's been going on for over a year. Those are the patients where, you want to make sure that they get treated.
So share your best motivational speech for walking as medicine. I remember when my dad was in there, it was, and it could be even a tip or trick for walking as medicine. But I remember when my dad was in there getting his chronic venous insufficiency test, that you ended up, telling me that a lot of people end up walking flat-footed. So they're not really
Yes.
using their calf pump.
They don't have a competent calf. So what we do is we exercise them by having them just flex your foot, and then we know they have a competent calf or not. So yeah, that does make a big difference in venous disease.
So share a defining moment in your career, or what we call the 6 minutes that matter. It could have been a conversation, a scene in a movie, or a documentary you watched, a mentor, something, someone, but make sure you describe who it is if there is a person involved so everyone understands. But what were the 6 minutes that mattered?
The 6 minutes that mattered, like a
Yeah,
mentor of mine.
yeah, the defining moment in your career. It could have been a conversation you had. It could have been a chapter in a textbook that led you in one particular direction versus another? Just a defining moment.
I think early on when I went to Yale and Dr. Taylor in detecting liver disease was very rewarding for me. Um, I think that was a big deal for me, and writing papers with him. Um, and also realizing that incidental findings do matter. I scanned a patient for Dr. Schubert a couple of years ago for an aorta. And I just happened to look, let's look at his gallbladder, let's look at his liver. We had liver mets. And I went in and told Dr. Schubert, and he says, oh, well, okay. And I said, no, nobody knows. He's here for an aorta. He said, well, I guess his liver mets are more important. And then I was also doing a patient with renal artery disease when I was at Good Sam, and we detected a pancreatic carcinoma. And
wow.
they came down and thanked me and said, you saved his life because they got it early. So I'm always thinking, for incidental findings, and I'm also telling, other people, sharing things with them, like this is an incident. If you are doing a carotid and you see a mass in the thyroid, they should know. You should measure that. You should tell them, is it cystic? Is it solid? Those are the kind of things that really you have to go above and beyond and find this incidental finding. So I guess in a nutshell, that would be my 6 minutes.
I love it. And I think with you, I think the defining, lesson is really ABC, always be checking. ABC, always be checking.
Always be
Go above
curious.
me. Always be
Always be
curious.
curious,
Exactly.
and little subtle things that can happen can make a difference.
And I have a fun one as kind of that final question. A moment with a patient, and don't say my dad. I'm just kidding. A moment with a patient that still has you shaking your head, something that patients can learn from. I mean, there are mistakes that patients make along the way. I can give you a few examples that people have shared if you'd like. But unless you have one on the top of your head, I know Dr. Hill has one. So I'm going to have him share one next. But what moment, Denise, has you shaking your head even still? I can't believe that patient did this or said that.
A patient that said something that was
Still has you shaking your head going, I can't believe. And while you're thinking, I can share a couple that would be you'd appreciate.
oh, I think
So you have one?
uh I'm trying to think about one in that
So we had a patient that stapled their socks up. They had diabetic neuropathy and they
oh
were tired of their socks going down. They stapled their socks up thinking that that was a good idea. And so
oh
you know what happened
I
next
heard
on that.
about that.
We had
Yeah,
another one
I
with your friend, Dr. George Adams, who told us about a patient that ended up using an enema for
drank it.
cleansing,
Yes, I saw.
but used it in the wrong cavity. Um,
Yeah.
so that was a little interesting. But
Well, I
Dr.
think a
Hill,
lot
you're
of
smiling
patients
down there.
get confused about arteries and veins. So they come in and say, my veins are clogged, when they really mean their arteries. Or I had a patient that told me once he had a skunk. And I said, no, you have a shunt, not a skunk. um, yeah, I mean, it's some patients will come in and say, I don't know why I'm here. And then I'll ask them, do you have this? Do you have that? And it's probably why you're here, you know? But yeah, some people do some strange things.
Well, and the most common one, I just to make it more, I think, kind of appreciated by the listeners. It's amazing how many people think that, smoking like 3 or 4 cigarettes a day is not really smoking, because you look at their history, it says no, this is a non-smoker. But unless you ask them specifically, and usually there's a family member in the room, and they'll confess to it, or the family member will say, "Oh no, you do smoke," and they'll say, "I only smoke, half a pack a day, or I only smoke, 2 cigarettes a day." And they've been doing it for 50 or 60 years. So, this is something that's very common where people don't really think their smoking is truly like smoking. So that's something that we actually hear a lot.
And I'm going to tap right onto that because I remember being at your lab one day and you had just treated someone and they were out front waiting for their ride and they pulled out a cigarette. I
Oh, yeah.
couldn't believe my eyes looking out the window. I was like, you've got to be kidding me.
Yeah. Yeah, it's true. I
You
mean,
just
patients, yeah, it's, I know smoking is the hardest thing in the world to quit. It's harder than
terrible to, it's hard.
heroin or, just
Yeah.
about any other addictive substance. But it is incredibly damaging, and
And it's
people
also
can't quit.
very rewarding when you have a patient come back, like the patient we were talking about with the stenosis, and she had a blue toe and she was a smoker. I think she also had a factor V. But our favorite podiatrist referred her, and Dr. Hill fixed her that very night. But when she came back the second time, I said, "Are you smoking?" She goes, "I'm trying." And then when I saw her, third time, she said, "I'm not smoking, Denise." And I said, "I'm so happy for you."
Yeah.
It just really makes a difference.
We have our smoking cessation program on Monday nights, and everyone's just at their own level. And I always tell them, we have one patient that said, I do really need to have a procedure. And I said, well, if you do really need and you have a wound on your toe, well, then, and it's the pain's waking you up at night, we'll definitely, go do that. But you need to know it's better if you can actually stop smoking at least 7 days before and clear out those arteries, get the oxygen flowing back in your blood. And I think that that's so important. And if they do need, and some of them they just do, we don't judge. We say, at least can you wait for a few weeks after you have the procedure, give it a little bit of breathing room. But it is better if they can quit. And it's always interesting. You have some that are able, as soon as they hear their legs on the line, up, quitting cold turkey, and they don't look back. And others, struggle. And it is a struggle. And we're always there for them every Monday night. We all get
Yeah.
together and
Yeah.
we try to help them through.
Yeah, too often,
That's great.
the patients wait until they have a heart attack or major
Yeah.
stroke or limb loss, and then they stop smoking. This happens far too often. And
Yeah.
I think that, the thing to realize is that it can be done. There are millions of patients that have stopped smoking. For many, it's like a light switch. I mean, there are patches and gum and
Yeah.
other things that can help, medications that can help people stop smoking. But it really is the one, most preventable contributing risk factor that we see in practice is still today's cigarette
Still
smoking.
smoking.
Yeah.
Yeah. And it's amazing. We had a patient that was in England that was in CLI, advanced stage critical limb ischemia, and had a wound. Well, it turns out her vessels were spasming. And the moment she quit smoking, up suddenly
That's right.
blood returned. It was miraculous. No more CLI. Didn't even have a procedure. She started walking again. She's doing
Wonderful.
great
That's
today.
wonderful. Yeah.
So thank you so much. Thank you,
Well, thank
my
you.
amazing co-host, Dr. Brad Hill. Thank you for helping us to celebrate the
Yeah.
amazing
50
Yeah.
Denise
years. My goodness.
Levy,
Years. Incredible. What an inspiration. What a
now
pleasure to work with you.
retired,
Yeah.
our 2025 Lifetime Achievement Award winner for Vascular Diagnostics. Thank you so much for all you have done and continue to do to save life and limb. We appreciate you so much. Congratulations.
Thank you so much. I'm so honored, and I love what you do. And thank you, Dr. Hill, for 4 great years.
Thank you.